Hi, everyone. Welcome to OsteoBites. Thanks so much for joining us today. My name is Christina Iptoma, and I am mom to Osteo Angel Dillon and Director of Scientific Programs at MIB Agents. And today on OsteoBites, we are joined by Dr. Matteo Trucco, pediatric oncologist at Cleveland Clinic and chair of our MIB Agents Scientific Advisory Board. And he's also our Factor Osteosarcoma Conference co-chair. Thanks so much, Dr. Trucco, for joining us on OsteoBites today. We are always thrilled to talk to you. And always happy to have Walker on as a panelist. Please feel free to submit questions during the presentation through the Q&A in Zoom, and we will share those with Dr. Trucco during and after his presentation. Our presentation is a little bit different today because we're actually just kind of giving everyone a sneak preview of what the scientific program is going to look like at Factor. So definitely feel free to ask questions along the way. A little bit more about our guest today. Dr. Matteo Trucco is a pediatric oncologist caring for children, teens, and young adults with sarcomas at Cleveland Clinic Children's. He also serves as clinical director and directs the Children's Cancer Innovative Therapy Program and co-chairs the National Pediatric Cancer Foundation's Sunshine Project Consortium, where he and colleagues develop and conduct clinical trials seeking more effective and less toxic treatments for childhood cancers. He received his undergraduate degree from the University of Pennsylvania, his medical degree from Temple University School of Medicine, completed his pediatric residency at Rainbow Babies and Children's Hospital, and pediatric hematology oncology fellowship at Johns Hopkins and the National Cancer Institute. And MIB Agents is very fortunate to have him on our board of directors. And as I mentioned, he also chairs our MIB Agents Scientific Advisory Board. And in that role, he co-chairs the organizing committee for the Factor Conference. And he also serves as a moderator for the MIB Agents Tumor Review Board for Osteosarcoma, which we affectionately call Turbo. So very excited to have him on today to kind of review the scientific program at Factor. And so today's episode really is all about everything, all about Factor. And we really hope you can join us. It is going to be June 26th to 28th, which is a Thursday through a Saturday in Salt Lake City. And our detailed scientific program is online. I will put a link in the chat where you can find that. We'll have 7 scientific panels that Dr. Trucco will run through today, as well as our very popular patient panel. And we also have 2 breakout sessions that Dr. Trucco will also share some details about. And those are really great opportunities to come to Salt Lake City and engage in the conversation at the conference. So I'll put a link in the chat on how to register, also where to book your hotel. We do have a discounted conference room block at the Grand America Hotel where the conference is at. So I will put a link in the chat where you can book your room. And so we have the best and the brightest in the scientific community coming together to collaborate on osteosarcoma at Factor, but it is really a unique conference in that it bridges the scientific, patient, advocate, and funder communities and gathers everyone in one place to work on solutions together. So we have a Warrior HQ for patients and siblings ages 8 to 22, which I'm sure Walker can give more details about if anyone has questions about that. Lots of fun activities throughout the conference. And more than anything, it's really just a great chance to bond with others who totally have been through and get the patient experience. There is also going to be a Factor formal this year after dinner, which is a fun opportunity to get on your dancing shoes and blow off some steam. And then grief coach Lori Krause will also be there to lead a Healing Hearts grief workshop for bereaved parents. And new this year, she is also going to be leading a session about navigating loss and transition, which is also directed to our healthcare providers, because we know that in this tough profession, our healthcare providers also suffer a lot of loss as well. We have wellness sessions geared for our families at Factor, including yoga and breath work, sound bath, flower arranging, even salsa dancing this year, led by osteo warrior Andrew, which I know Walker has been waiting for a long time. And then even a morning run with Dr. Trucco. So he's obviously a man of many talents. So when you come to Factor, you are going to be intellectually inspired, you're going to be emotionally re-energized and reinvigorated. And it'll give you the chance to connect with mentors, peers who share your passion to make it better for osteosarcoma patients. And think of it as kind of like a spa weekend, but also for your mind. All right, so that's my pitch for Factor. Walker, do you want to go ahead and introduce yourself?
Yeah, hello. My name's Walker. I'm on this year's junior advisory board and have been for the last few years. I've been to the last two factors, and I have to say they're definitely a great time. This year, I'm going to try to spend less time at HQ and more time at the actual panels. And so I feel like joining today will probably help me get a head start because it can definitely be a little confusing. But I'm very excited to hear more about them. And Dr. Trucco, you can take it from there.
Thank you. Thank you, Christina, for all those kind words. And thank you, Walker. And I need a rematch with Jenga at the next factor. Can everyone see the slides okay?
Yeah, that looks great.
Perfect. So, yeah, this is just a primer on factor. I will tell you the speakers are world class and they don't hold back as far as kind of the scientific information they speak about. And truth be told, even the other docs in the room aren't familiar with all the terms, and there are several that I had to look up myself because this is really the cutting edge of science, and so it's hard to keep up. And so we thought having a little OsteoBites session of just going over some of the terms, some of the concepts of what's going to be discussed at the Factor Conference will help people kind of when they're actually there, understand the actual presentations a little bit better. Not summarizing anybody's talk, just kind of going over some of the highlights and some of the terms that might be discussed. With that, we have 7 panels, as Christina mentioned, with a couple breakout sessions, and we'll go over them one by one. So first one, biological drivers of osteosarcoma. What is osteosarcoma? Where did it come from? And how does it keep going and keep doing what it does? And once we understand that, we'll be better set up to stop it. So we have a panel of 1 moderator and 5 speakers on this topic. Again, world class from a bunch of different institutions from around the world. Really looking forward to this. And some of the terms they're going to be throwing out and explaining what drives osteosarcoma. I'll go over now. The first one is this thing up here, oncogenes. So we all know our cell is full of DNA in the nucleus of the cell, and that DNA is like the instructions for making proteins, actually, and kind of how to make things grow and create life, quite frankly. So it's not like we have genes built into our DNA to create cancer. That's not what these oncogenes are. They serve a purpose, but perhaps they serve the purpose in the embryo to go from a single cell to a full human being, or they're important during specific phases of growth, and then they get shut off. But if they get inappropriately turned on by some reason in some cell, specifically a bone cell, suddenly that might be something that might turn into a cancer. So that we call those anything that's kind of turned on and leads to a cancer, an oncogene. The flip side is also exists. There's these things called tumor suppressor genes. And these maybe do play a little bit more of a role in specifically being engineered to existing to suppress cancer development. But for example, the TP53, this is one of the most mutated genes in all of cancer, and especially in osteosarcoma. Basically, its job is if there's some damage to the DNA in a cell, it says, okay, everybody stop. Let's figure out what's going on. Let's either repair it or let's get rid of this cell. And if you can imagine, if there's a mutation where P53 doesn't work, mutations can happen in DNA, damage, errors can happen, and cell won't stop. It'll just keep dividing and keep accumulating more and more errors, and you might start turning on some oncogenes that aren't supposed to be turned on, and that'll lead to cancer. So again, cancer is probably a combination of genes that are supposed to be turned off that lead to growth being turned on, and genes that are supposed to be regulating things being damaged or shut off for whatever reason. I'm going to shift over to the middle to signaling pathways. How do these genes have their effect on a cell or on the world? The genes copy the DNA to RNA. That's transcription. The RNA then goes outside of the nucleus, goes to the ribosomes, and those create proteins, which are then folded and do what they do, either make things grow, make things spread, make cells divide, what have you. That's how they do that is signaling pathways. One protein stimulates another one, which makes another one change, which makes one go up, which makes one go down, which feeds back. And that's how one simple message from the DNA can then have a huge effect on a cell. And so sometimes we can't target the gene itself, but we can kind of see or target the signaling pathway later on. Going over here to epigenetic modifications, the DNA isn't all just laying there ready to be read. It's actually packaged up in these coils, which kind of keeps it closed off, not being read. And there are specific epigenetic modifications, as term, where it's uncoiled so that the genes can specifically be read. And you can imagine if something has coiled up the tumor suppressor gene so they can't be read, that could lead to a cancer. And if it's uncoiling things like oncogenes that are not supposed to be read anymore, that could lead to a cancer. So it's not just the signal itself, it's how that signal, how that DNA is packaged seems to be having a big effect. Microenvironment is kind of outside of the cell. You can have two exact same mutations in a tumor cell, and yet if they're in different environments, they're going to behave differently and they're going to respond to that microenvironment differently. And that includes how close they are to a blood vessel, how the immune system is around there, how much oxygen is in that area. And all those things play a role on how our treatments might work on those cells and also how that cell behaves. I'm going to pause there. Any burning questions popping up? Okay. Feel free to type them into the chat. And I can't see the chat, so Walker, it's on you to stop me if I'm going blah, blah, blah. Okay. The second panel is mechanisms of resistance and evolution. So this is fundamental to what we do. We have pretty good medicines. We can surgically remove tumor, but it comes back. It becomes resistant to the treatments that we're doing. And the question is, why does that happen? How can we overcome that? And again, we have one moderator and 5 speakers on a variety of topics kind of tackling this. And, you know, one term that comes into play and has gotten more and more discussion, especially in osteosarcoma regarding this, is evolutionary biology. It's like, what does that have to do with anything? It's the study of species and how they change over time. Well, if you think about a species, the dinosaurs, the passenger pigeon, the dodo bird, what have you, any species that has gone extinct, you can ask yourself, why did that happen? And it's not just that one thing happened and wiped them all out. Maybe you could argue that happened with the dinosaurs. The running theory is a giant meteor hit the Earth and changed the climate and the environment so dramatically that all the dinosaurs passed away. But if you look at more recent extinction that's happened, the passenger pigeon, the dodo bird, a few of those, any of the species on the endangered species list, it's because of hunting, it's because of habitat loss, it's because of some infection going through the already dwindled population, it's because of one of the foods that they eat going in short supply. And those things kind of build up upon each other and eventually lead to an extinct population. What does that have to do with cancer? Well, the theory is there's certain rules that populations follow based on evolutionary biology, mathematical rules, kind of pressures on the population. Similar rules might actually apply to cancer cells, because all cancer cells is a population of cells responding to various pressures, and our goal is to make cancer cells extinct. And so are there any lessons we can learn from evolutionary biology and apply them to cancer? Because if you hop over to clonal evolution, cancer cells don't stay the same. They keep changing. Every time they're dividing, they actually make more errors in copying their DNA than normal cells. And so they keep changing. And if one of the mutations is more effective in growing and surviving, that becomes the dominant population. And so you can see how you started off with these white cells, a mutation came up, and suddenly this yellow clone is the more popular and robust one. That one becomes a dominant one. Then you get this blue one with the 2 dots, and that one becomes the more dominant one. So again, trying to understand this will hopefully help us stay ahead of resistance and lead to extinction. Hopping back over here to selective pressure, that's what's causing the cancer cells to respond. A perfect example of this is, I believe it's in England, there's this one type of butterfly that's like white with black speckles on it. And these butterflies live on birch trees, which the bark is white with black speckles, and they're perfectly camouflaged there. Every once in a while, a butterfly is born that's all black. And they're actually somewhat rare because they stick out like a sore thumb on the white birch tree, and they get eaten right away. Well, come the Industrial Revolution, there's a bunch of smoke from the smokestacks actually polluted the trees, and all the trees were black, covered in soot. And suddenly, the black ones had the survival advantage. They became camouflaged on the black trees, while the white speckled ones stuck out. And suddenly, the population shifted. Black was much more population was almost predominantly black, with every once in a while a rare white one would be born and would quickly be eaten. Fast forward, and with cleaning up air pollution and all that, the trees became white again, and it flipped right back. So that's the idea of selective pressure. And something like chemotherapy does just that to cancer cells. It will kill the cells that are sensitive to chemotherapy, but the ones that are resistant will suddenly become the predominant ones. And we have to be mindful of that to figure out how we can stay ahead of this resistance developing and kind of trying to control the populations. How do these mutations happen? How do this resistance develop? A lot of different ways. And structural variants is one of the ways where it's just big changes in the DNA. A piece of this chromosome breaks off and joins with this one. There are some other cancers, especially in pediatrics, which are driven by 2 pieces of chromosomes breaking off and attaching to each other, creating a new gene that's not supposed to be there. That's not necessarily what drives osteosarcoma, but those changes certainly do happen in osteosarcoma. Single nucleotide variants, that's like in the DNA changing just one of the letter. And that happens a lot, and usually it doesn't matter too much. But imagine if you're reading a murder mystery and you're in the last chapter and the detective says, and the murderer is, and it's supposed to say Sam, but the S is changed to a P, and suddenly Pam is being blamed. Again, one single change completely changes the story, and that can happen in DNA. And so it depends where those errors might be, could have a profound effect. Copy number variants, there it's the chromosomes, they get copied, and one copy goes to each cell when a cell divides. But sometimes when they copy, 2 might go to one side, they might make more than one copy. And so those things can kind of duplicate. And so you end up having more than the normal 2 copies of any one gene or chromosome in one cell. And having more than the standard number of copies is going to affect how the cell responds to those changes. All these things can cause more mutations and cause the cancer cells to behave differently, which again, responding to selective pressures, will create some sort of evolution so that the original tumor is not necessarily the same as the tumor later on in time, or as a tumor grows, not all those cells within that tumor are going to be the same. Any questions on this group? Okay.
Yeah, those were helpful pictures, though. Thanks.
Thank you. And thank you, Christina, for prepping a lot of these slides. All of them, actually. Tumor heterogeneity and tumor microenvironment interactions. So we talked a little bit about the microenvironment. I'll go over that a little bit more. And then tumor heterogeneity gets at what I just explained, is in one tumor, not all of the cancer cells are going to be exactly the same. They're actually going to be a lot of different subpopulations within a tumor like osteosarcoma. Again, Rosie Kaplan's going to moderate that session with 5 speakers, all great speakers looking at how we can understand kind of, in a way, it's still microscopic, but it's not at the DNA level. It's kind of a little bit taking a step back. One of the techniques used a lot in trying to understand cancer cells in general, but cancer cells is, so we have whole genome sequencing. That's where you just understand all of the DNA. And that's great, but as we talked about at the beginning, not all of the DNA is being expressed all the time. RNA sequencing is not the genome, but the transcriptome, if you will, is just what message is leaving the nucleus and telling the cell to make proteins. And the SC here is single cell RNA-seq. So you can see each individual cell, what signals is it sending out to make new proteins. And so that's one way to kind of see the different populations, because different groups are going to be sending out different messages, even though they're all osteosarcoma cells. And that can give us a lot of insight. Spatial profiling can actually be paired with single-cell sequencing in that looking at a tumor, again, under a microscope even, you can see where the cancer cells are, but you can also see where the blood vessel is, where the immune cells are, where other kind of normal tissue cells are, and how their interaction might play a role in allowing the cancer to be resistant to any therapy, how that enables it to spread and grow and move throughout the body, and how it sets up new tumors and metastases throughout the body. So all those aspects are important, and we've gotten to the point where we can physically make a map looking at it and seeing how these various cells and components of the body interact with each other. Totally separate topic, but chemotripsis is basically, you talked about the kind of mutations that can happen in DNA. This one is kind of taken to an extreme. We have our DNA packaged in chromosomes. Each one of us has 23 chromosomes. Great. They're organized in a specific way, but there's something that happens to cancer cells, especially something like osteosarcoma, where P53, the master regulator of kind of checks and balances to make sure DNA stays intact, if that doesn't work, something like this where the whole chromosome just gets shattered and reassembles in a random way. And you can imagine chaos ensues after that. Things that are supposed to be on are off, things that are supposed to be off are on, and it just changes the picture dramatically. It seems chaotic, but at some point, one of these, if this is happening thousands, millions of times, you might, even by just coincidence, pure luck, random event, create something that is resistant and growing at an uncontrolled rate. So things like that are happening all the time. Intratumoral heterogeneity just means that not all the cells within a tumor are the same. And again, that could be because of mutations. That could be something practical like the blood vessels in the middle of the tumor and the ones that are on the side, far away from the blood vessel, aren't getting as much oxygen, and so they're behaving in a different way. Maybe they're growing slower. Maybe they're not growing at all, and they're just kind of sitting there quietly, which has some implications because a lot of the chemo we use works on cells that are dividing. If a cell is not dividing, it's not going to be susceptible to chemotherapy. So there's a lot of difference even within one single tumor. doesn't even have to be big. A tumor this big has a lot of heterogeneity in it. Intertumoral heterogeneity is looking at how tumors from different patients, these are all osteosarcomas. They can all be osteosarcomas from the distal thigh bone in a 15-year-old male. Like, everything can be very similar, and yet there's going to be some differences within those tumors. And what are those differences, and how do those differences explain why some respond very well to treatment, others don't, and what can we learn about those to better understand osteosarcoma and come up with better therapies? Questions? Okay. Still looking at that kind of microenvironment, there are other players at play. Stromal cells, those are kind of support cells. They don't actually necessarily do stuff, but they kind of help feed other cells and can actually help protect the cells, the cancer cells, in some respects. They can help move things so that the cancer cells can spread. They can help grow new blood vessels or things like that to feed the tumor. Cytokines, those are signals. They're small proteins secreted by cells. We usually think of cytokines as related to the immune system. When you have an infection or something, of an immune cell will send off cytokines to kind of recruit more, or the body can send off cytokines to say, hey, immune cells, come over here. A lot of that also happens in the tumor microenvironment, but sometimes it's the immune cells actually getting hijacked and sending out those signals that actually say, everybody calm down, don't attack us. And the cancer is using these immune cells and these cytokines to suppress the immune response, hence surviving when it shouldn't. Hypoxia is just the measure of oxygen. So lower oxygen changes how a cell behaves and how it divides. And we've actually seen differences in oxygen levels within tumors. And again, you can actually, in the lab, have chambers where you can drop the oxygen level to near zero and see how that affects the cancer's behavior. And obviously, a cancer is going to behave differently at kind of 21% oxygen that we have in the air that we breathe, and the much lower amount of oxygen that we have in our tissues. And especially something like bone can have very low oxygen levels. Cancer-associated fibroblasts, those are a kind of stroma. They're there to kind of help the tumors grow and spread, and they remodel the microenvironment. If you imagine if you bought a steak or a chicken breast or something, it's not just falling apart. There's something kind of holding it together. And that's actually the extracellular matrix is kind of connective proteins holding everything together. And that's what you use, a tenderizer or marinade or brining to break down that connective tissue. And that exists in the microenvironment, and it can affect what the immune cells can do, how the tumor moves, can also affect how chemotherapy gets into a cancer cell. Any questions? Okay, moving forward, halfway there. Integrative approaches to advancing osteosarcoma immunotherapy. That's using the body's own defenses to fight off the cancer. And I feel like every year, me and Christina are like, okay, we don't need another immunotherapy session this year, do we? We've had one for the last 7 years, and nope, there's some very interesting immunotherapy happening, and so we end up having an immunotherapy session. So again, very exciting work. Eugenie Kleinerman from MD Anderson's moderating, and we have 6 speakers on this topic. Again, there's always something in immunotherapy. So a couple of the terms, I hit on some of these before, but so we talked about the genome. That's like all of the DNA in a cell. We have the transcriptome. That's all the RNA in the cell. And the DNA makes the RNA. The RNA then tells the cell what proteins to make. The complement of all the proteins that a specific cell is making is called the proteome. And again, that's even more kind of functionally what's happening. What is this cell doing? So studying that is very important. And that can play a role in the immune system as well. Nanovesicles, these are little bubbles, little fat globules with some information inside, whether it's protein, more fat, or some genetic information that cells use to communicate to each other. Not completely understood how or why, but there is some interesting data out there that maybe the cancer is flicking off these teeny tiny little bubbles of information. They're not cells, they're just little bubbles with stuff in them that then go to the lungs, for example, and somehow those vesicles communicate to the cells in the lungs, hey, make this place comfortable for some cancer cells to come. And then lo and behold, the cancer cells come and set up shop in those areas. It's fascinating. It's like calling ahead to a hotel to make reservations and to have the beds turned down and, this is the bottle of wine I want in my room. Apparently cancers can do that to some degree in the lungs. So very interesting area. The immunopeptidome. So this and surface proteins are actually very similar. All cells express proteins on their surface. And in fact, it is proteins on the surface that the immune system recognizes and can say, oh, you're foreign, you shouldn't be here, I must get rid of you. Or, yeah, you're cool, okay, carry on. Kind of like a police officer checking IDs. Cancer cells tend to have some proteins that don't belong on the surface of a cell. And we try to exploit that because we can target those because those are not expressed on normal cells, but they are expressed on cancer cells. So if we can train the immune system to recognize those proteins, they can attack the cancer and leave the normal cells alone. So the immunopeptidome is kind of, again, that kind of global view of all the peptides, which are pieces of protein, expressed on the surface of a cell that the immune system might recognize. And so by getting a better sense of all of that, we can then find new targets that might be expressed either only on cancer cells or at higher levels on cancer cells and less on normal cells. Virus-specific T cells. So T cells recognize, take a step back. When you get infected with a virus, be it the cold virus, herpes, HIV, you name it, basically the virus gets into a cell and kind of hijacks the machinery of that cell to make more viruses, which actually means it injects its DNA into the cell, and that DNA is converted into RNA, and then that cell makes the proteins to make more viruses. Part of those proteins to make the viruses get expressed on the surface of those cells, and the T cells come by, recognize those, and say, oh, you're a virus. You're a virus-infected cell. I must get rid of you. And that's how vaccines work, is we expose the body to some of those proteins so that the body learns to recognize them, so that if you do get infected with a virus, the body's that much faster at recognizing those proteins and eliminating those cells. It's not that you don't get infected, it's that your body's that much faster at getting rid of them. So that's great, and T cells do a pretty good job of getting rid or at least controlling infections with viruses, but can we use that to get rid of cancer cells? And so kind of using some of that machinery to recognize cancer cells and attack them. And truth be told, the immune system, depending who you ask, yes, we use it to fight off infections, but the real role of the immune system is to control normal cells, meaning allow normal cells to continue to live and eliminate abnormal cells. So cancer is almost inherently a failure of the immune system because it'll let one of these abnormal cells get past its defenses. And that gets into immune evasion, what is it about these cancer cells that are clearly abnormal, clearly aren't behaving, clearly aren't supposed to be there, that the immune system doesn't recognize? And we've heard on some past factors, and I'm sure in various other talks, of the kind of don't eat me signal that a lot of cells have, and that a lot of cancers have taken advantage of. These are called immune checkpoints, and they're literally proteins on the surface of the cells that when the T cell comes by and recognizes that, it says, oh, not supposed to eat you, okay, moving on. Or sometimes the T cell dies itself. We have developed immunotherapy to block that signal, hence taking the brakes off the immune system and allowing the immune system to attack those cancer cells. It's worked in some cancers. Haven't figured out how to make it work for osteosarcoma yet, but certainly a promising area, and people are actively working on this. Any questions on that? Okay. Precision medicine. How to get the right treatment for the right patient, because no two tumors are alike. You know, we use MAP, and MAP works pretty good for decent amount of people, but it's a blunt tool, and we want to get much more precise, and precision medicine is the way to go about that. Dr. Sweet Cordero from UCSF is going to moderate, and we have 5 speakers with all kinds of interesting approaches. So a couple things that help us kind of be more precise with our treatment. One thing is biomarkers. So biomarkers are signals that are either on the tumor or floating around in the blood that kind of can clue us into whether a specific tumor may or may not respond to something, or is there cancer there in the first place. Other tumors, for example, we know that they secrete this substance called alpha-fetoprotein, which is really high in babies, but it drops down pretty quickly, and in any buddy above a few years old, it should be very low. For certain cancers make alpha-fetoprotein, and so if you measure alpha-fetoprotein and it's sky high, whoa, you might have one of these tumors. And usually you're not going to go looking for alpha-fetoprotein willy-nilly, but if you see someone with a liver mass, and you know one of the tumors that happens in kids secretes alpha-fetoprotein, let's check alpha-fetoprotein levels, it's sky high, okay. You probably have hepatoblastoma. You can treat the patient for the hepatoblastoma, and then you don't even necessarily have to scan. You can just check their blood every so often, and if the alpha-fetoprotein level goes up, that raises concerns for a recurrence. As long as it stays low, they're probably okay. Wish we had one of those for osteosarcoma. We don't. But we are starting to get more information about which osteosarcomas might behave differently than others. Where we might have a little more information on that is gene signatures. And there it's, again, looking at all the DNA, or at least all the DNA that's being transcribed, and seeing if you can kind of pair it out to like the ones that responded nicely, or the ones that are metastatic and the ones that aren't metastatic, or the good responders, poor responders, and try to make a map like this of genes that tell us, okay, the bad responders tend to have these genes turned on, these genes turned off, while the good responders have these genes turned on and these genes turned off. And you can kind of split them out into 2 groups, and they might help us risk stratify, next topic, our patients, saying they're not all the same. Just because you know, 2 patients both have an osteosarcoma of the distal thigh doesn't mean they're the same. If one has a gene signature that suggests that they're going to do very well with MAP chemotherapy versus another one that is unlikely to do well with MAP chemotherapy. What do we do with the one that's unlikely to do well with MAP chemotherapy? Well, we don't have an answer with that yet, but the first step is let's identify those patients, and then kind of let's focus our attention on those to maybe try to come up with better therapies. Multiomics is basically taking all those omics that I mentioned, the genome, the transcriptome, the proteome, the immunopeptidome, the metabolome, which is all the metabolites that cancers or cells use and make, and put them all together. And you probably need a really big computer to analyze all that data, because it's huge amounts of data, even for one cell. And then you do it for multiple single cells, and it just becomes a lot of information. But hopefully, by looking at all these layers, we'll gain insight into what might be some sensitivities to these cancers, and figure out the specific sensitivity of the specific cancer that a patient has. Fortunately, each patient, as we discussed, has multiple populations of multiple different cancer cells, all within their osteosarcoma. So again, it adds a layer of complexity. But again, maybe we can kind of get a much more global understanding of a patient's osteosarcoma, and with that knowledge, come up with a better treatment for them. Liquid biopsies is sort of along the lines of what I was describing with the alpha-fetoprotein and the hepatoblastoma analogy. If you could, instead of scanning, instead of getting biopsies of the bone, if you could just get a blood test and figure out, does the patient have a lot of cancer and a little bit of cancer? Is the cancer gone? Is the cancer back? We don't have that yet, but I can't tell you how many patients come into my office and say, well, can't you just do a blood test to tell me if I have cancer? And it's like, unfortunately, no. I think Theranos was that company that said they could come up with all kinds of stuff from just a drop of blood. We're not there yet. Doesn't mean we won't be there. But the concept is liquid biopsies is somehow doing a blood test that will give us information about the blood, be it risk stratification or some sense of the burden of the cancer in the body. One of those is circulating tumor DNA. CT is circulating tumor DNA, which measures tiny bits of DNA from the cancer cells floating around in the blood. And again, higher levels tend to suggest higher tumor burden. You can imagine if that goes to zero, that's great. But if you're kind of no evidence of disease and everything's zero and your scans are normal, but we check your circulating tumor DNA and you suddenly start seeing some circulating tumor DNA again, that raises the concern of, could the cancer be back? And the thinking is maybe that's going to be even more sensitive than a scan. Because on a scan, we need to be able to see a tumor big enough to be picked up on a CT scan. And along those lines, there's also something called circulating tumor cells, which Dr. Hayashi is one of the speakers in this session. He's looking both at circulating tumor DNA and circulating tumor cells and seeing if those are predictive of tumor coming back or of how likely it is that you're responding to therapy and stuff like that. Questions on those? Okay, clinical trials speaks for itself. It's trying new therapies to see if they work. Always a popular panel, because we want to know what's going on out there. In really all of that preclinical work is designed to come up with better treatments. So got 5 trials that they're discussing. Some terms when talking about trials, ultimately we want to know, will this treatment cure more patients? We're like, okay, well, how do we define cure? Well, to be perfectly honest, if a 15-year-old boy has an osteosarcoma of his right thigh and you want to see if he's cured, basically you have to wait till he dies of natural causes at 80 years old. That's going to be one heck of a long clinical trial, and it's going to take a long time to get an answer. So we have to use different endpoints. And what we've largely used is something like disease-free survival or progression-free survival or overall survival at 5 years. Sometimes we use shorter term. 5 is kind of where if you made it 5 years, the chances of you recurring are not zero, but are much less. And so usually we use kind of 5 years as a good cutoff. Sometimes it's something else that they're measuring. It's just, are you responding to therapy? And that might be the endpoint. Or they're looking at something more like quality of life as the, what are you actually measuring on the clinical trial? Overall response rate, that gives us some information about how effective the treatment is against the specific tumor. Usually you measure it either as a partial response or a complete response. So you can imagine if you have a tumor this big, partial response is if it kind of shrunk a little bit, but it's still there. Complete response is where it goes completely away. The challenge with osteosarcoma is that, as we know, osteosarcomas make bone. And so even if you have a lung nodule that's, this big and it's calcified, you can give them extremely effective therapy and it can kill the whole cancer. And on a scan, it's still going to look this big. Why? Because it laid down bone. That's basically a fossil sitting there in your lung. And that makes measuring response using the standard traditional techniques of measuring it on a scan extremely difficult. Certainly made things difficult for osteosarcoma. As we're developing therapies that are more effective, we also want to make sure they're safe. And one thing that we measure is adverse events. That's anything bad that happens to a patient while on a trial. That could be hit by a car. Counts as an adverse event. May not be related to the treatment, but it counts as an adverse event. Side effects is another word that might fill in for adverse events, though, again, adverse events is a little broader. Dose-limiting toxicities, that's what we measure. And on a clinical trial, usually lay out, okay, these are the things that we're going to keep an eye out for. We know this drug is toxic to the bone marrow. We want to make sure the patient's blood cells recover. And if we're knocking it down too far or too many people are having too high of a toxicity in this specific realm, then the dose is too high. We're going to limit the dose, give a smaller dose. The way a lot of trials, and usually it's the phase 1 trials that are trying to find the right dose to use, they're going to use dose-limiting toxicities to try to find the maximum tolerated dose. And usually it means no more than 1 out of 3 patients are going to have a toxicity, a high toxicity at this dose level. Sometimes you never actually get to a maximum tolerated dose, and you settle for what's called a recommended phase 2 dose. Again, you may be able to push the envelope even higher dose-wise, but maybe the drug actually works, or maybe this is the dose that you wanted to use anyway because it worked in another cancer, so you don't have to push it any higher. But the term we use is recommended phase 2 dose, and since we like abbreviating things, it's RP2D. MTD is maximum tolerated dose. DLT is what we use for dose-limiting toxicities. AEs is what we use for adverse events. We love abbreviations. Questions on that? Okay. That's it for kind of like the biology lesson, if you will. One of the other panels we have is collaborative data ecosystems. And one of the best things, if you ask me, about Factor is that it brings people together, people doing similar things and working together. And this is kind of like a team of teams. Each of these groups are collaborating already on osteosarcoma, and we're kind of bringing together the groups that are collaborating on osteosarcoma to collaborate together. LifeArc is a nonprofit trying to kind of work across industries to transform and innovate and bring scientific breakthroughs to the clinic. and they have a pediatric bespoke therapeutic development workshop in osteosarcoma. Osteosarcoma project was funded by the Moonshot Initiative, and it's the Count Me In project through the Broad Institute that's looking at kind of some of the germline mutations in patients who have osteosarcoma. There's efforts in China where, again, kind of the most populous country in the world, India, but trying to, again, assemble the data across all of its centers to see what they can learn. Foster is an effort of 350 experts in 19 countries and based out of Europe, specifically focused on osteosarcoma. Iconic is kind of take that thing, but just in England. But again, a lot of experts throughout England working together, and they talk to the Foster people. Breakthrough Cancer is not yet in the osteosarcoma world. We're trying to get them interested in osteosarcoma, but it's an effort to get 5 of the major cancer centers in the country to collaborate and share data and share resources to work together. And Breakthrough Cancer oversees that. They've done initiatives in several different cancers, and we're hoping that they will tackle osteosarcoma next. So great having all these people together to hear what they're doing, the challenges they've overcome, how they've overcome them, and potentially even see them all interact with each other. And wait, there's more. So 2 breakout sessions during Factor. One is the Cure OS working group. So this actually started 2 or 3 years ago with several of the panelists and others working on just generating a lot of single cell data on osteosarcomas. And again, each of these people had a handful of, more than a handful, but some samples that they generated this massive amount of data. But obviously, if you compile all of their data together, it's going to be much more robust, much more useful than if they each kind of hoard their own. And it was one of the beautiful things of Factor is bringing them together, having them sit next to each other, and next thing you know, they're collaborating and so on and so forth. So they've been meeting independently between the Factor conferences, but it'll be great to kind of hear what they're up to and how they're collaborating on their various efforts. On the flip side, the other breakout is mentorship in sarcoma. Again, maybe single cell sequencing is not your thing, and that's okay, but taking care of patients, how do I get into oncology? How do I get into oncology research, sarcoma-specific research? We have a panel with some truly excellent moderators and moderators for sure, and mentors to pair up people to try to help them out, and hopefully that'll kind of blossom into kind of long-term and productive relationships. We have our patient panel, which is always one of the highlights of Factor. It's, doctors getting the chance to ask their patients what they've always wanted to, but were afraid to. And then we get to announce the Outsmarting Osteosarcoma Awards, which, again, we've picked some fantastic research that we're going to be funding this year. With that, I will stop talking unless someone has a question that I can answer.
Thank you so much. We still have a few minutes for any questions if anyone has any. And Dr. Trucco, I feel like we need to get you like a Gatorade and a cold towel or something. It's a lot. I know, it was like definitely Osteosarcoma 101 in 45 minutes or less. So thank you for summarizing all that so well. Walker, I don't mean to put you on the spot, but do you have any other questions too that you want to throw out, or even feel free to share any experiences from Factor?
I guess for precision medicine, do you know if there'd be anybody there discussing like pharmacogenomics, looking at kind of how the like different genes interact with drug metabolism, and maybe looking at that for like map and everything?
Yeah, none of the speakers are, but I have a pharmacogenomics study that we just opened, and one of the things we are actually trying to focus on is methotrexate, because that seems to be like everybody metabolizes this drug in a completely different way. So we just started out, but it is a fascinating field where, you give two people the same dose of Motrin, they weigh the same amount. One of them, it works. The other one, it doesn't. Why? Well, because they break it down differently. And, as a kind of screening, I swabbed myself and had a metabolomics, pharmacogenomics profile done on me. And apparently, if you want to kill me, give me morphine. Like, good to know. Yeah. I don't metabolize it very well, apparently. So yeah, it's a fascinating field, very early. And not a lot in pediatrics and not a lot in general. But that is something that we're working on here at Cleveland.
Gotcha. Do you mind if I ask how many genes are on that panel?
It's a lot. I want to say like 230.
Oh, wow.
Now, do we know what to do with all 230? No, but it's a lot.
Gotcha.
Yeah. It's actually through a commercial company. It's OneOme is probably the leader in the field. We were doing it in-house, but then that person left. And so we partnered. We got a grant from OneOme to do through them.
Very cool. Thank you.
And before Factor, I will find the actual number for you.
Okay. Sounds good. I'll be waiting for it.
And I will, correct me if I'm wrong, Christina, but this was recorded. So people can come back to this and kind of play it back and slow the speed down a little bit.
I did love some of it. Like, and now I'll always be thinking of those nanovesicles as like the concierge of cancer.
When I heard about it, I was like, so they're like literally making reservations in the lung, and like, I guess.
Yeah, those are interesting, but also very helpful to help you remember what their role is. Yeah. And always appreciate the intellectual curiosity, Walker. I will say that we need to congratulate Walker because it's apparently just finished his last final of college, and he ran back to his room to join us on OsteoBites of all things. So thank you, Walker.
Great way to end the year.
Yeah. Thank you so much. So great stuff happening at Factor. And again, thank you so much, Dr. Trucco, for kind of running through all that so well, and kind of just giving us some kind of great ways to kind of think about it, like also the black butterfly on the smoky tree, which is another great way. I'll always think about that now when I think of selective pressure. So really appreciate you taking the time to join us on OsteoBites and for making it better for the osteosarcoma community. So this is going to be recorded. It has been recorded. It is going to be on our YouTube channel. And so you can find this there, as well as more information on OsteoBites on our website at mibagents.org and at your favorite podcast place. And we are going to be back with OsteoBites in a couple of weeks, May 29th at the end of the month. We are actually going to be joined by Dr. Yingqi Hua, who is a professor of orthopedic oncology from Shanghai General Hospital and the Shanghai Bone Tumor Institution. And he is going to discuss his lab's work on molecular subtyping of osteosarcoma, ecDNA, and more. You can find our OsteoBites lineup for the next few months on our website. And if you have any ideas for future topics that you'd like to hear about, please feel free to email us at events@mibagents.org. Thank you again, Dr. Trucco and Walker, for spending an hour with us today. And thanks to all of you for taking time out of your day to join us. And we hope to see you back here on OsteoBites in a couple of weeks. And we hope to see you in person at Factor in Salt Lake City. Thanks, Dr. Trucco. Thanks, Walker.
Thank you.
Thanks, everyone.
Thank you.
Pleasure.
All right,
Take care.
Bye.
Bye.